Welcome, everyone, to the Penn Primary Care Podcast. I'm your host, Dr. Kendall Williams. So one of the most common causes of both morbidity and mortality in the world is stroke. And we don't talk enough about it, partly because it's complicated. There are different types of stroke. They present differently. And certainly since I've been in training, there have been a lot of changes in how stroke is evaluated and at least initially how it's treated. So I really wanted to get on two experts to talk about stroke, both in the inpatient environment and in the outpatient environment, so that we can all get up to date on all the latest aspects of caring for this very common condition. So I invited an old colleague of mine from Presbyterian Hospital, Dr. Christina Blum, to come on. Christina is an associate professor of neurology in stroke neurology. She is the medical director of the primary stroke program at Presbyterian, as well as inpatient neurology program. Christina, thanks for coming.
Thanks so much, Kendall. Excited to be here.
And also joining us is Dr. Kristy Yuan. Dr. Yuan is also an associate professor of neurology, does both inpatient and outpatient work, inpatient both at HUP and Pennsylvania Hospital. She's also does a lot of QI work in neurology on the outpatient domain. And Kristy, thanks for coming.
Thank you. Great to be here.
So I wanted to start really with the basics because there's been some definitional changes. When I was in training, a TIA was symptoms lasting less than 24 hours. That's changed. So I think we all know what stroke is. It's a focal loss of neurological function due to an issue of blood flow, hemorrhagic or ischemic. But within that, let's just first take a moment and talk about stroke itself definitionally, and maybe contrast that with TIA. Maybe, Kristy, I'll start with you.
Yeah, so stroke is when, as you say, there's different types of stroke. So if we were to break that into ischemic stroke and hemorrhagic stroke, ischemic strokes make up about 80% of all strokes and hemorrhagic about 20%. And ischemic stroke is when you have a blood vessel that is blocked and that part of tissue is injured. There is frank tissue injury that you can see on brain imaging. And a TIA is when you have a transient vessel blockage and the tissue may be at risk, but somehow unblocks itself and does not cause permanent injury, but it's still a clotting event. And so, in many ways, the workup and the approach to ischemic stroke and TIAs are similar, especially the workup, as we'll talk about later. And hemorrhagic strokes is a totally different entity. And there are many different causes that some of the risk factors are the same between ischemic stroke and hemorrhagic strokes, but the spectrum of etiologies for hemorrhagic stroke is different.
Yeah. Christina, anything to add there?
Yeah, no, I think that that's exactly right. I think the one thing I like to add when I'm talking to medicine colleagues and ED colleagues is that TIAs are important because they indicate a future risk of stroke, and that future risk is not trivial. So kind of the quoted percentage risk of stroke in the next 3 months after TIA is like 10%, but that can be higher depending on the mechanism, which we can get into. And we can tell patients, like, just because you feel better doesn't mean that you are better. And so recognition and early evaluation is important, just like a stroke. And yeah, even if you have focal neurologic deficits that resolve and they last 5 minutes, if you do an MRI and you see evidence of tissue damage, as Kristy was saying, then that is a stroke, not a TIA. And strokes, if you have persistent neurologic deficits lasting greater than 24 hours, but for some reason you can't get an MRI, but you can localize the deficits, and for some reason you can't get an MRI because the patient has a fresh pacemaker or severely claustrophobic or has a contraindication, stroke can still be a clinical diagnosis if you think that you've excluded other etiologies.
Yeah, and definitionally, my understanding is that TIA has changed because of the advanced imaging that we now can do. And we're going to get into imaging in a little bit. But I think a lot of what we used to categorize as TIAs, we're now seeing are actual strokes that people recover quite quickly from, or they compensate from, right?
Yeah, I mean, that's exactly right. I think that there's a lot of variability, and it kind of depends on where in the brain the stroke happens, the extent of the burden. So, right, symptoms of stroke and TI can vary depending on the part of the brain that's involved. And some patients think that they've had quote unquote TIAs because I think people use the colloquial kind of term, I had a mini stroke. But when you actually ask the patient, well, how long did your symptoms last? Or first of all, what were your symptoms? Were you weak? Did you have trouble speaking? And they say it lasted more than a day, or, oh, I was better by a couple of weeks. That actually was a stroke. It's just eventually they recovered.
And I think I wanted to bring up the term mini strokes too. And I'm glad Christina brought it up because I think in lay terms, it sounds nice. It sounds easy to understand, but I really try to disabuse some patients from using that term and just go with stroke is injury on the brain, and TIA is when you did not have injury on the brain, but you still had some transient stroke symptoms.
Yeah. And TIAs are important. We're not going to necessarily talk a lot about TIAs in this podcast. By the way, I didn't say this up the beginning, but we're going to focus mostly on the inpatient side and then on the outpatient side. But when we do the outpatient version of this discussion, we should talk about TIAs because those could easily present to us in outpatient care where a patient has had transient symptoms. We might send them for an MRI and it's negative. We say, hey, yeah, you're good. Everything's fine. But that's actually just the beginning of the workup, right? Because if their clinical symptoms suggest stroke, but the MRI is negative, then that still does require further workup.
Yeah, I like to say that the number one single most important study, if I had to choose one, is vascular imaging. And so that's something that we can revisit as we continue this discussion, but very important.
Okay, so let's just go a little bit basic about mechanism, right? So we talked about ischemic strokes are the most common. So a blood vessel's been blocked. And the question is, how did it become blocked? We distinguish between embolism and thrombosis, generally, when we talk about these. And generally, patients who have, let's say, a myocardial infarction and they have a thrombotic event where there's fracturing of plaque and a clot is formed and so forth. But in strokes, where that may be an aspect, we also have the phenomenon of embolic large vessel artery to artery embolism of a cholesterol laden plaque, right, Christina? Am I thinking about that correctly?
Yeah, absolutely. So kind of all of our approach to stroke workup, secondary prevention, everything, it is based on what's the underlying mechanism. And so there's three main buckets of stroke mechanism or etiology, and then kind of a fourth bucket or even a fifth sub bucket. And so they are large vessel disease, small vessel disease, cardioembolism, and then up to a third of strokes kind of fall into this category of cryptogenic, but now we kind of think more about cryptogenic as embolic strokes of undetermined source or ESIS. And so within large vessel disease, there are different ways that a stroke can occur. So you can have progressive plaque buildup and then plaque instability, rupture, occlusion of that large artery. And large vessel disease can affect any of the starting with the arch, the common carotids, the basilar's, the verts, the ICAs, the middle cerebral arteries, PCAs, ACAs. We think about those as the large arteries. So plaque instability, rupture, occlusion, or artery to artery embolism. So maybe a piece of plaque breaks off and then causes a distal blockage. And then the third is flow failure, hypoperfusion, which tends to occur more when there is a stenosis that's hemodynamically significant, really greater than 70%, but more on the order of kind of closer to 80 to 90%. Do we start to be worried about flow failure? And of course, hypoperfusion is definitely more of a concern if you have hemodynamically significant stenosis and some sort of insult like relative hypotension. So those are sort of the three sub-mechanisms of large artery disease. And then small vessel disease refers to disease of the small penetrating arteries or perforating arteries coming off of the large intracranial vessels. So all of the large intracranial vessels have perforating arteries coming off of them. So the basilar, the posterior cerebral artery, even the PCOM, the intercerebral artery, the middle cerebral artery, those all have perforating arteries that supply deep structures of the brain. And so when we look at a scan, depending on the distribution, if it's small, less than 1.5 centimeters in size, and in the distribution of a small perforating artery, then we think about small vessel disease. And then cardioembolism refers to embolism to these intracranial vessels or the distal branches. And cardioembolic strokes can look a lot of different ways on imaging, but sometimes can be multi-territory, but also a single cortical stroke could be due to cardioembolism or strokes in the posterior circulation. And then generally we think about our high-risk cardiac sources such as AFib, significantly reduced ejection fraction, recent MI with left ventricular thrombus, valvular disease, etc. And then The category where you don't fall into those buckets is cryptogenic, or kind of what we call embolic stroke of undetermined source. And then there are other additional mechanisms that we think about, such as less common mechanisms like vasculitis or drug use, etc.
Syphilis. I've seen one
Right.
case of that in my life. I actually want to spend a little time on this mechanism thing because, at least when I was in training, we talked about ischemic and hemorrhagic strokes, but we didn't get a lot of detail. We all knew that we had to do carotid evaluations in patients that had either a TIA or a stroke and so forth. But so if someone has a middle cerebral artery stroke, a large stroke, which is common, is that a thrombotic event? Let's say it's not embolic from the heart, but is that a thrombotic event in which that vessel has had a thrombus? Or is it that a large piece of plaque has caused a large artery to artery embolism?
So it depends, I guess, is the answer, because it depends on whether there's intrinsic disease of the middle cerebral artery itself. So it could be due to large artery disease, and then you have kind of progressive stenosis, plaque instability, rupture, occlusion of the entire artery, and then you might see a cutoff, and or it could be that a cardioembolic event. Sometimes heart embolism can lodge at different places of the vessel, and so sometimes depending on where the occlusion is, we might think about different mechanisms, or if we have prior imaging that shows maybe underlying stenosis, and then the patient comes back with an occlusion, maybe that could clue us in. But I guess the answer is it depends. And so usually we think about just the broad category of cardioembolism when we're thinking about embolic events to the brain. And then within large artery disease, we think about artery to artery embolism or atherembolism, or just thrombosis of a severely stenosed vessel.
Yeah. So when we worry about carotid artery stenosis, for instance, it's 70% or greater, we're most worried about it because that's a large enough amount of plaque that you're at higher risk for an artery to artery embolism, right?
Yes, extracranial carotid disease, or intracranial carotid disease for that matter, is one of the highest risk stroke mechanisms, but really when the narrowing is hemodynamically significant. And so anything above 50% we start to pay attention to, but particularly anything greater than 70%. But why someone is high risk, that actually also depends. So it might be that there's narrowing and there's complex plaque that's ulcerated and mobile. And so then there's artery to artery embolism occurring from that. But once you start developing more of a critical stenosis, then other mechanisms might come into play, such as actual flow failure. And then how susceptible a patient is to symptoms or strokes depends on the rest of their vasculature and their anatomy, and kind of what's their collateral status.
We use this term lacunar strokes, and they're different. When I learned all this, we learned that lacunar strokes could present differently. They're often milder. They could be pure sensory, pure motor. You had this clumsy hand syndrome that we talked about and so forth. And that maps to the small vessel strokes that you referred to, where these penetrating arteries, right? And is that currently the understanding of what we call lacunar strokes?
Yes, absolutely. So when we use the term lacunar stroke, that kind of implies that we think the underlying mechanism is small vessel disease or intrinsic disease of those small perforating arteries that have either focal athero, or another pathophysiology is lipohyalinosis, hardening of the arteries. Over time, due to traditional risk factors, people develop kind of reduced cerebrovascular reserve. That can happen at any level, but particularly those small vessels over time develop reduced compliance, and then you get a stroke from kind of occluding those perforators. And then that group of patients that have those types of strokes, they're actually at risk they can be very unstable in the early period and can stutter. So that term, stuttering lacoon, that's because patients can complete their infarct over days, even with the stroke mechanism. Sometimes that's just the natural history of that type of stroke. And the syndromes that you mentioned, pure sensory, pure motor, dysarthria, clumsy hand, sensory motor, yes, those are kind of patterns that we tend to see symptom patterns that we tend to see when patients are coming in with those strokes.
If I could just add that lacunar strokes don't necessarily have to be mild. They can be pretty devastating just depending on where they hit and the real estate that it affects.
Yeah, absolutely. In fact, and this is something I would say, there's kind of two types of stroke mechanisms make me the most nervous. The first is large artery disease, either extracranial or intracranial. And the second is small vessel disease, because a patient might come in with mild face, arm, leg weakness, and then on your exam, you just see a mild facial asymmetry, a little bit of a drift, and then by the next day, they could be plegic. And so there are approaches to early management and certain measures that we can take that can try and mitigate that, as well as early antithrombotic therapy, et cetera, thrombolytic therapy if they qualify, but then beyond that, permissive hypertension, et cetera. But sometimes that's just the natural history of that type of stroke mechanism.
So the other thing that we have to deal with in primary care is patients will come to us and we're concerned that they may have had a stroke. So I actually want to go over some of the basics of presenting stroke symptoms and maybe some pearls that we should look out for. Because you're talking about a focal loss of brain function that can present in a myriad of different ways. So you often think of stroke, but maybe how do you teach your residents this? What to look out for? What are the patterns? Maybe some pearls in that area, just in clinical presentation.
So, stroke symptoms vary depending on the part of the brain that's involved. Usually, when I'm teaching stroke symptoms to trainees and students, what I sort of do is I show them a slide where I organize the symptoms into the anterior circulation, posterior circulation, and then I have symptoms in the middle. The symptoms in the middle are that can localize to either the anterior posterior circulation are the motor symptoms, sensory symptoms, or a Horner syndrome, or just dysarthria, slurred speech that can localize anywhere. And so, starting with the posterior circulation, we can list out a few. We can think about acute, spontaneous, unprovoked dizziness, gait instability, diplopia, vision loss, specifically visual field loss, slurred speech, discoordination of a limb, or just a general feeling of my legs aren't doing what I want it to do, etc. And then I also kind of have headache in there, even though headache in and of itself is not a stroke symptom, but can accompany other symptoms. So, for example, someone who has cerebral stroke might develop sudden onset acute spontaneous dizziness and some gait instability that's persisting and not going away. And then they start to feel kind of a posterior headache kind of in the back near the cerebellum, or someone develops left-sided weakness from a right MCA distribution stroke, and then they kind of start to develop a headache on that side. For double vision, very important for vision in general. Sometimes patients are not good at describing their vision complaints. Some are. So, for example, someone might say, I started seeing double and I saw two images side by side, and then I covered one eye and those two images became one. That would be a very useful history, but usually patients are not going to volunteer that information. And so if someone is complaining of diplopia or double vision, the questions that are very important to ask are your images side by side, diagonal, or on top of each other? And then what happens if you close one eye? So if the double vision resolves when you cover one eye, that means that the eyes are misaligned and that could be a potential brain problem. In particular, if someone is having diagonal or vertical diplopia that resolves with one eye closed, invariably it's going to turn out to be an upper pontine or midbrain problem. Another important point I make, in addition to in the category of vision complaints, is when patients talk about blurred vision or they can't see right. Rarely is someone going to report that they have a field deficit. They might say, I was watching TV and I suddenly couldn't see the right half of the TV, and then I covered one eye and I still couldn't see the right half of the TV. That would be nice if they would report that, and then you might suspect a field cut. But it's very important to do a full visual field exam in anyone with nonspecific vision complaints. Anecdotally, and also just in the literature, patients often present very delayed when they have posterior circulation strokes and PCA distribution strokes in particular, because the vision complaints are hard to pick up on. So we might ask, are you bumping into things more than usual? Or did you get in some sort of unexplained car accident? Maybe you didn't see the stop sign. And sometimes you can get odd behavioral changes with PCA strokes. And so it's very important to ask questions in the history and then do a complete visual field exam. And then in the anterior circulation category, language, I should say that language is not only in the anterior circulation, but we generally think of it as that. Patients can appear confused, but they're actually aphasic. And so another very, very important point, and I particularly with the emergency medicine physicians that I give lectures to, is making sure that anytime someone appears confused, you're doing a complete language exam. So not just, hi, how are you, and some orientation questions, but asking them to name a few objects, maybe increasing level of difficulty, asking them to repeat simple and longer phrases, and seeing how fluent they are and kind of comparing it to their baseline and their level of education. It can sometimes be very hard to tease out.
is that when we're trying to find out whether a neurologic symptom is a ischemic syndrome, or if it's stroke or TIA, is we're looking to see whether their deficits follow a particular vascular territory. And so it may not make that much sense for someone to have true aphasia and still have left-sided weakness, because all of that aphasia should be in your left MCA territory, which might affect right-sided weakness, but maybe they have multifocal strokes, or things to that effect. But there are two kind of additional symptoms that we commonly get called about that can be a little bit tricky, problematic to think about. And Christina kind of highlight one of them, confusion, and then the other is dizziness. And so confusion, absolutely right to do a full language exam. But there are some cases, I would say most of the time, if you just have altered mental status, it's usually not stroke unless you have nothing else to explain it. You do brain imaging, and then there's bilateral strokes, or a stroke in the midline structures that affect your reticular activating system. And for dizziness, it's sort of really hard. There's many questions that we like to kind of pin down to patients. Usually, when someone has isolated vertigo, it's unlikely to be an ischemic syndrome, particularly if it's short lasting. And then particularly if it's position triggered. They're not always position triggered. And part of our exam in looking at different kinds of eye movements would help us differentiate whether that dizziness, if they're still having it in the moment, is more of a central process or peripheral vestibular process. But when someone talks about dizziness and it already happened, I'm trying to figure out if it's a TIA or maybe it already got better, I'm usually looking for some other signs or symptoms. Are they listing towards one area? Like, do they feel unsteady, like they're on a boat? Do they have, in fact, some other brainstem findings? You can have dizziness rarely from an anterior circulation stroke. So it's like, I definitely had people who were just dizzy, and then you MRI them, and then they have some kind of left MCA stroke. So it is possible to say that, like, despite all the categorization that we want to do, it is sometimes hard, and very high risk patients, you might just want to MRI them.
Yeah, that's a great point. And I think just to add to that, kind of another framework that we keep in mind when we're evaluating stroke symptoms is, in addition to where in the brain could this be, kind of what is the mechanism? And so everything comes back to localization and mechanism. And so the way we think about it is something on the right side of the brain or the left side of the brain, and are there cortical signs? And so in the acute setting, when we're evaluating someone, the high yield things to check, in addition to strength and sensation and language, are the cortical signs, which include whether someone has a gaze preference, which could suggest that there's a problem with the frontal eye fields. And I'll come back to kind of localization of that in a second. Language, so aphasia, either trouble speaking or understanding, field cut, and then neglect, which is inattention to one side of the world. And then related is something called extinction, where someone cannot process either seeing two things on both sides at the same time or feeling two stimuli on both sides at the same time. And extinction is something that we, the examiner, have to check. Neglect is something that we can observe. And so we're always checking these cortical signs in the acute setting, and then looking at the sensory and the motor component and the language, and then thinking about where in the brain could this be? And am I dealing with a cortical problem, which might raise my suspicion for a large vessel occlusion? And then kind of another basic concept is just kind of having an understanding of what a left MCA syndrome looks like, or a right MCA syndrome, or posterior circulation. And so left MCA, generally speaking, we think about language with right-sided weakness. Most people have language in the left hemisphere, including people who are left-handed, though not everyone. And then right MCA syndromes, we think about left-sided weakness with hemi neglect. In either of those, you can have a gaze preference towards the side of the stroke. And then for posterior circulation, we worry about vertical diplopia, vertical eye movement abnormalities, significant speech difficulties, or unexplained ability to manage secretions, dizziness, crossed sensory signs. So, like, meaning someone has numbness on one side of the face, but then opposite side of the body.
When I was in training, or at least earlier in my career, I remember reading about the posterior symptoms of stroke and the 5Ds. So it was dysarthria, dysphagia, diplopia, dizziness. And the fifth, I think, was discoordination, which is basically a cerebellar side. And that was very helpful, I thought, just in terms of those symptoms, especially if you had more than one together. We see dizziness. It's ubiquitous in primary care. So, and of course, we could do a whole different podcast just on the workup of dizziness. It's actually a pretty good idea to do that with
Absolutely.
the hints battery and some of the other tools that we could do. That actually may be something we'll want to do. But
I just want to recommend Lindsay Agostinelli as a neurologist who now is our kind of like neurology trained disease specialist.
Yes.
that's
She
great.
has running a dizzy clinic, I think, at Penn.
Oh, that's
Yeah.
great. So I'm going to have her on. So we could talk about dizziness. And then I think, Christina, you outlined some of the more anterior symptoms, the cortical symptoms you described, and an exam to work up that. So that's all very helpful. Now, let's talk about imaging because things have changed a lot, right? So we all know about CTs. We know about CT, non-contrast CT. I always make the point when I'm teaching on this, you're not doing the CT to find the stroke, at least a non-contrast CT. You're not going to see it. That's not why you're doing the CT. You're doing it to rule out hemorrhage as a potential cause of stroke, but it doesn't tell you anything about an ischemic generally, at least within the time window in which we would want to find something. But MRI is still the best test to be able to see a stroke, whether it has happened or not. But Christina, you mentioned that CT angiography or vascular imaging was the most valuable single test that you find. Can you elucidate that further?
Sure. So I guess to follow up on your point about acute imaging, yes, CT without contrast is our acute imaging of choice. We use it to rule out hemorrhage, and we use it to look for early infarct signs, and we use it to make our immediate thrombolytic decision. We use CTA head and neck as our acute vascular imaging of choice, and that's to look for large vessel occlusion and make any thrombectomy decisions if indicated. And then we use CT perfusion to evaluate, to help us in conjunction with the non-con head CT and the vascular imaging to determine whether there's tissue that's irreversibly infarcted versus area at risk. Once we're beyond that acute period, then we're doing our MRI to confirm the location, the presence and the location and the distribution of the stroke, which helps us think about the etiology and guides our workup and secondary prevention. The vascular imaging, if not already done, it should be done very early on. Number one, because we want to make sure the patient does not have large artery disease, either in the neck or in the head, which could inform their risk for early recurrence. And we tend to be more worried about those patients when it comes to their risk of early neurologic deterioration. And so that's the main reason why we want early vascular imaging. We want to know the status of the vessels. We want to know, is there a hemodynamically significant stenosis that's going to put them at higher risk? Nobody should leave the hospital without vascular imaging who comes in with stroke or TIA symptoms. And so because large artery disease is the highest risk stroke mechanism, and I would say rarely we have readmissions for neurologic reasons within our kind of stroke population that gets discharged, but when patients come back, it's the patients who had symptomatic large artery disease.
So if I take us into the ED bay, right? So Christina, you've been called down to see a patient, acute stroke symptoms, clinically looks like a stroke. You're ordering a CAT scan. I know the stroke guideline, I actually give a talk on this for a CME audience. So I know that non-contrast CT has always been the preferred study of choice because MRIs take too long, right, to determine whether or not a patient is a candidate for thrombolytics. But you mentioned also CT angiography, CT perfusion. And I understand that those can be done now very quickly. Like MRI, it takes too long, but CT angio and CT perfusion can be done very quickly, almost as quickly as a CT non-contrast, right?
Yes, that's correct. If a patient has IV access, the whole process can take 10 to 15 minutes max. Yeah, you actually do not want to see a stroke on the head CT. If you see a well-developed stroke on the head CT, which shows up as a dark area or what we call a hypodensity, then you know that you're dealing with a more completed infarct or kind of you're too late as far as reperfusion therapies go. And so we explain that to patients that just because your CT does not show a stroke doesn't mean you didn't have one because the MRI is going to be better. So yes, it's pretty quick to get the CT, the CTA, the CT perfusion. Usually we default to doing all those studies at once. we may cancel them on a case-by-case basis. But particularly now, there's evolving evidence that is increasing the types of patients that can be candidates for thrombolytic therapy. And so within the 4.5 hour window, it is standard of care to give thrombolytic therapy to patients presenting with disabling ischemic strokes with no hemorrhage on head CT, who have no contraindications of thrombolytic therapy, to help improve their likelihood of good functional outcome. But beyond the 4.5 hour window, the new AHA guidelines now state, and now there's even additional studies that have been published since the publication of the updated acute ischemic stroke AHA guidelines this year, that state that patients presenting outside of the 4.5 hour window up to 24 hours from last known normal with disabling stroke symptoms may benefit from thrombolytic therapy if they have a very small area of irreversible infarction, which is measured with the help of the CTP, and a certain degree of an area at risk. And so all of that imaging is used in the acute decision-making period while also looking at the patient and how severe their symptoms are. And it's very individualized. It's a very individualized decision depending on the patient.
So initially, when we had the initial thrombolytic studies, it was based on this sort of arbitrary time window. When did we see that there was benefit for patients? And initially it was 3 hours, and then it was extended to 4.5. And that's where we are right now. Now, what's changed, is my understanding, is that you can now identify, not so much based on an arbitrary time window, but you can, based on the perfusion studies, identify patients that may benefit even out to those extended time windows, right? Is that the change that allows you to now think about extended time windows? Now you have CT perfusion imaging. It's not, there's an area of risk that if you were to reperfuse, the patient would achieve benefit.
Right. There's about a 9 to 10%, depending on what study you look at, about a 9 to 10% absolute increase in likelihood of excellent functional outcome for patients who are treated with thrombolytic therapy within the 3 hour window. And it's slightly smaller in the 4.5 hour window, but it's statistically significant with no difference in mortality. And that's been well established ever since the pivotal NNDS trial and the ECAS 3 trial were published many, many years ago. The curve for benefit crosses after the 4.5 hour mark, and that's when the bleeding kind of risk exceeds the benefit, and that's been well established. But the CT perfusion is kind of taking into account the physiologic characteristic of what's going on at the level of the stroke, and identifying whether, if the infarct is not far along enough, even though they're outside of that window, then the bleeding risk is still not high enough to exceed the benefit, if that makes sense.
Yeah, it does.
And I'm happy to go into the details of the trials and the nuances, but it depends on how far you want to get into it.
No, I do want to, in the time remaining, I do want to hit on mechanical thrombectomy, because for years there was this effort to achieve what was done in cardiology, right? Where initially we had streptokinase thrombolytics that were given in the setting of MI, and then TPA improved upon that. And then eventually we were able to angioplasty vessels, right? And then emergent angioplasty evolved, and then stents that went from there. And that actually eventually superseded the thrombolytic approach, the ability to open the vessel with a procedure, right? And so for a lot of years, in my career at least, I watched these studies come out that used various thrombectomy devices, and it just didn't quite, there were a lot of failed trials, right? And then, I remember, I guess it's been about 10 years now, that all of a sudden, all these trials came out and they were positive, where they showed benefit. And my understanding is because that was the development of stent retrievers, which is the ability to deploy a stent and suck out a clot all at the same time in one fell swoop. And that's really changed the landscape in terms of the acute treatment of stroke from a procedural perspective.
Yes, absolutely. I think the first step was getting FDA approval for alteplase for patients who were candidates for that, and then tenecteplase being shown to be non-inferior to alteplase and easier to administer, and at times even better for patients who had a concurrent large vessel occlusion. And then mechanical thrombectomy is available for those patients who have large vessel occlusions causing disabling strokes, because some patients are not going to be candidates for thrombolytic therapy. They're going to have contraindications. Maybe they're on a blood thinner, or perhaps a patient does get thrombolytic therapy within the window, but they also have a large vessel occlusion. And so maybe thrombolytic therapy is not enough for them. So the recanalization rate or the likelihood that that vessel opens after thrombolytic therapy varies. It can be anywhere from as low as like 10 to 15% if it's an ICA occlusion up to maybe 40% with a large vessel occlusion. And so mechanical thrombectomy with stent retrievers is the procedure that's done. And those negative trials you mentioned, they were not as successful because they were using older devices. And then there was some issues with patient selection and how they were initially seeing whether there was an occlusion and whether there was a lesion to go after, and their recanalization rates were not as high. And then the pivotal trials all were concluded and presented and published between the years of 2014 and 2015. And as you said, it changed the landscape of stroke. I was a stroke fellow, and the results of the Mr. Clean trial were announced at the World Stroke Organization conference. And so essentially, this was a randomized controlled trial that looked at patients coming in with anterior circulation, large vessel occlusions, so mainly ICAs and proximal middle cerebral arteries, causing disabling stroke. And they randomized them to get standard of care or mechanical thrombectomy with stent retrievers. And so if the patients were in a thrombolytic window and had no contraindications, they would get the treatment as planned. But then if they were randomized to get mechanical thrombectomy, then they would get the procedure. And then they looked at excellent functional outcome at 3 months as the primary outcome, which is generally the primary outcome in all of these intervention trials. And the results were overwhelmingly positive in favor of thrombectomy, with no worsened bleeding or mortality, or even better mortality. And so there were other multi-center randomized controlled trials across the world that had similar results, and then the guidelines were changed thereafter. And then beyond that, there was a suggestion of benefit even beyond sort of the 6-hour period, because these trials were enrolling patients and intervening on patients in the earlier time windows. And that's kind of where CT perfusion came in. And so the landmark trials were Diffuse 3, and Dawn, that looked at the 16-hour window and the 24-hour window respectively, using imaging and clinical criteria using CTP to select patients for mechanical thrombectomy. And again, the results were overwhelmingly positive in favor of thrombectomy, with excellent numbers needed to treat. And so really compelling results. And that has changed the landscape of stroke.
And I think despite all of the advances, and we've of course like keep pushing the boundaries with enrolling or seeing benefit, even functional benefit, not just mortality benefit, in patients who already come with large cores of stroke. So they already have large stroke, but not a complete hemisphere, but large enough, and yet they still select patients in that category can still derive some benefit. But in more recent years, I would say if we're talking about updates, there's been a little bit of pulling back. I would say that we would at one point be doing a lot of thrombectomies on branches of the MCA, M2s, maybe even distal M2s. There's certainly off label PCA thrombectomies, ACA thrombectomies, depending on the situation. And in the last couple of years, there are trials looking at thrombectomy of the M2s, particularly like a non dominant M2 in select patients, and haven't found as much functional benefit. And I think that there are ongoing trials regarding that, depending on patients who have had lower stroke scales versus higher stroke scales, depending on what their imaging looks like and their collection of, their morbidity factors. But so I think it's still a very dynamic area that is constantly checking itself, not just expanding itself, but maybe also checking itself.
So I want to ask you about few different scenarios here. So if you're within the 4.5-hour window and you have a stroke, clinically a stroke, in the modern day, you're going to get thrombolytics, right? Up front, if you're a candidate, right? Yes.
That's correct.
Okay. Now, there are patients who fail thrombolytics. They don't have any benefit within that. They get within the 4.5 hour. Those are candidates for thrombectomy. Then you have the patients who present after 4.5 hours, and they would potentially be candidates for thrombolytics based on CT perfusion studies. But you also said that there may be benefit for mechanical thrombectomy up to 24 hours, even as much. I assume that's also based to some degree on perfusion studies. And then finally, there's the issue, and this is what you're getting at, Kristy, that you really have to have a thrombus that's accessible to a stent retriever. And so we were really looking at these large vessel strokes, MCA and so forth. But then, Kristy, you were getting at this issue. There are these strokes of smaller vessels, M1, M2, ACA, PCA, and so forth. and that's a little fuzzier, right? I guess that was supposed to be a question, but also maybe a bit of a summary of what you said. Is anything I said there incorrect?
Yeah, no, I think you summarized it well. I think so. So thrombolytic therapy is the standard of care up to 4.5 hours from what we call last known normal, which is not symptom discovery, but last known normal for patients with disabling ischemic stroke, disabling, which is assessed based on the neurologic exam, the stroke scale, and depends on the patient. In patients who have disabling ischemic stroke with a large vessel occlusion in one of the proximal large vessels, that includes distal vert extending into the basilar artery, the intracranial or extracranial internal carotid arteries, and the middle cerebral arteries. It's generally well established that if a patient has an occlusion in one of those vessels causing a disabling stroke, then they're a potential candidate for mechanical thrombectomy, just based, and if they're within 6 hours, you don't need CT perfusion usually to make that decision. Beyond 6 hours, then we tend to look more at CT perfusion, but again, it's an individualized decision. Thrombolytic therapy and mechanical thrombectomy are not mutually exclusive treatments. So if someone is a candidate for thrombolytic therapy within the 4.5 hour window and they happen to have a large vessel occlusion, you would get both treatments. Then where it gets a little trickier is in the extended window. And so the patients in the extended window, meaning for thrombolysis, which is 4.5 hours up to 24 hours, if they have a large vessel occlusion and they're going to go to thrombectomy, then that's the treatment they will get. The patients that benefited from extended window thrombolysis generally, and the patients that were excluded in the extended window trials were that the ones that we're relying on to now change our practice were patients that were not otherwise going for mechanical thrombectomy. And so in those patients, we're looking at the CT perfusion imaging to look to see about the size of the core versus the area at risk and whether they have a disabling stroke and no thrombolytic contraindications. So it's a very select patient population that might benefit from extended window thrombolysis that is not otherwise going for mechanical thrombectomy.
Yeah.
And the trials that show positive benefits for that extended window, and there have been several leading up to the practice guideline change, they tend to be lower stroke scales earlier. So maybe not closer to 24, but closer to 12, like medium 12 hours or earlier. And they have fast imaging selection, maybe not just at places that have rapid MRIs. They can use MRIs. Most of the time, in most institutions, they'll probably be using CT perfusion. But Kendall, you mentioned something earlier about if those patients who get thrombolytics don't improve, then they go to mechanical thrombectomy. I distinctly remember early in residency when I was going to stroke alerts, we would wait. We would wait and see whether after giving TPA, like, did it get better? Then we just activate the team. But that's really not the practice now, where we just, as a system, because everything it takes a village, and you have to move fast. It takes so many people. So stroke as a system has really been a lot more rapid. So we basically activate right away as soon as we see that CTA show the large vessel occlusion. And then if by chance, by the time they get to the OR and they have completely improved or they only have very, very minor deficits, then we abort the case. And so I think the system's development has also improved functional outcomes in addition to the stent retrievers and everything else.
Right, absolutely. When we have patients come to Presby, which is one of our primary stroke centers, we have early activation clinical criteria. So if someone comes in, we look at whether they have a gaze preference, neglect, aphasia, or a field cut with hemiparesis. And if they're coming in with those deficits and they're within 24 hours of last known normal or unknown last known normal, then we're doing what we call early activating transfer, even before we see the CTA, to get that process going. And if they do happen to be a thrombolytic candidate, because we're able to confirm their last known normal, and they have a large vessel occlusion, sometimes they get tenecteplase and go to HUP, and they're fortunate enough to open up their vessel and clinically improve before they need the procedure. So every situation is different, but it's very dynamic, and the systems piece is extremely important, making sure that the workflows are in place to help get the patients where they need to be quickly.
Yeah, Christina, the patient you described with a gaze preference in it, you basically know this is a large vessel stroke, right? You can see that clinically. So you're getting the process aligned for them to get mechanical thrombectomy. And with tenecteplase now, you're able to give it much quicker, right, as sort of a bolus up front, as opposed to TPA, which I think was a longer period of infusion, right? So you can give them an infusion, and then they're on their way to the lab while you're seeing if the thrombolytics are working. And if you make that decision when the time they get to the lab, right, Kristy? Is that what you're saying, that you used to give it and then wait, and now you don't wait anymore? They're on the way to the lab before you even, after you've given the thrombolytics, they're on their way and you're ready to go if they haven't improved, right?
That's right. Once they've are in a safe space where they get the thrombolytic and the OR say we're ready, then they roll over to the OR. And this is all after you've already had the CTA and CT perfusion imaging.
I wanted to highlight one other thing you said, and that is you mentioned basilar artery thrombectomy, right? And so, it used to be that you would have a posterior circulation large vessel stroke, and it was terrible. I mean, there was nothing you could do. You'd sort of say, really, that, and then some of these strokes were really, truly terrible. But now there are some options, right? And so I think that's a newer thing in even the thrombectomy literature, that it's more recent that we know that we can do basilar artery thrombectomy and open up those strokes, right, in the posterior circulation.
Yeah, there are several trials that have shown benefit in select moderate to severe posterior circulation strokes with basilar occlusions or vertebral artery occlusions extending into the basilar basics, best attention, some of the studies, but they are still strokes that carry high morbidity. So I think that it's an option, but those strokes can still be very disabling.
Yeah. And so, Kristy, just to go back to the point you were making for some of those smaller the arteries obviously taper as they get further into the vascular tree, M1, M2, and so forth, where thrombolytics remains probably our best strategy for those, right?
That's actually a very interesting area. So it just kind of depends on how severe their symptoms are, what their NIH stroke scale presentation is. So someone may have a full M1 occlusion or even an M2 occlusion and their stroke scale is 0 or their stroke scale is 1 or 2. There are trials looking at what to do with those patients. But for the most part, if you only have a deficit of a stroke scale 1 to 2, we're probably not taking you to thrombectomy. Depending on how bad those deficits are, if it's language and it's disabling, we will probably give you TNK. But if it's sort of mild weakness or numbness, facial, then there's a whole other category of antithrombotic medications that we still consider acute treatment. And later, I know we'll discuss later about TIA patients, but consider TIAs and minor strokes they're all emergencies, and telling patients that it's not just the thrombectomies and the thrombolytics that you can get, but also dual antithrombotic loads of medications, and there's many different types now that we can use. Some of them are still being studied that help stabilize the blood vessel and prevent deterioration within the first 7 days and then within the first month. So just to name a few, I think a lot of internal medicine primary care doctors probably know about aspirin Plavix load and plus 21 days of aspirin Plavix after a minor stroke or TIA. And these are usually for stroke scales less 5 or below. You can also use aspirin ticagrelor combination that's been studied in the Thales trial for these acute presenting TIAs or minor strokes, even up to possibly even 3 days. Sometimes people use beyond 3 days of presentation as long as they don't have hemorrhage or large stroke already on head CT. And then there's very exciting area of factor 11 and factor 11A inhibitors, asundexian, milvexian. Asundexian has been studied in the oceanic trials for stroke, for minor strokes that are non-cardioembolic. So if you have an undifferentiated stroke, ESIS, where you know it's non-cardioembolic stroke, giving asundexian or some kind of factor 11A inhibitor in addition to usual therapy, whether it be single antiplatelet, dual antiplatelet therapy, does reduce the risk of recurrent stroke. And I think factor 11 is worth mentioning just because I think it's going to be very prominent in the next few years. Its benefit lies in that you don't need factor 11 for hemostasis, but it's critical for thrombosis formation. So if you inhibit it, you limit thrombosis, but hemostasis is really not affected, so it doesn't really affect the risk of bleeding, unlike Plavix, ticagrelor. other medications. And so it really is an exciting thing that I think it's probably already starting to change the field, but there's no practice guidelines on it yet. There's many things to be verified. But I think that's a drug that's worth knowing about.
Yeah.
Yeah, that's definitely going to be practice changing and coming. It's the first drug that actually will reduce recurrent ischemic stroke without increased bleeding risk. Aspirin and Plavix and ticagrelor and the other drugs that are studied, they all have benefit, but with a small increased risk in bleeding. And so that sets the factor 11 inhibitors apart and is exciting.
Are they out and you're using them now?
Not
Not yet.
not yet.
Not yet.
There
Coming.
needs to go through, I believe, FDA approval, and
Yeah.
we'll see about the cost. But I think that we anticipate that, we hope that it'll be widely available, but we shall see.
Yeah, and I just want to hover back on this dual antiplatelet therapy. I used to teach the residents dual antiplatelet therapy is a cardiology thing. It's not been beneficial in neurology with stroke, but that changed, right? And just to highlight this for everybody, because it is a change, that within this window at which people are most at risk for another event, right? Another stroke is in that maybe a month, 2 weeks, 4 weeks, whatever period, that early period after an initial TIA or stroke. And it's in that window now that we know dual antiplatelet therapy. Kristy, you said both with aspirin and Plavix. I think the initial trial in China was done with aspirin and Plavix. And then you mentioned also now aspirin and ticagrelor. Again, you're only doing dual antiplatelet therapy for a shorter period of time, right? Initially, I think it's 21 days. I don't know about the aspirin ticagrelor, how long you do that. And then you go back to a single agent therapy with either aspirin, Plavix. I don't know if you could do single agent ticagrelor or not. Maybe you should educate me on that. But I wanted to highlight that for the audience. That's a change.
Yeah, absolutely. The Chance Point trials and Thales, all of that was very exciting for the stroke world. And I would say most of those trials enroll patients who are just presenting within 48 hours initially of their symptoms, whether it be minor stroke or TIA. So usually 1 week out would probably be too far. So if a patient said while in your office that last night I had this, it may be worthwhile to send them to the ER to get the acute imaging and all the acute treatments, which I would consider this dual antiplatelet load an acute treatment.
Yeah. And it's the kind of patient that we might see in our office because, just to be clear, we're talking about minor stroke and TIA. The major strokes that we've been kind of addressing, the middle cerebral artery, those folks are not who we're talking about dual antiplatelet therapy. They're getting the thrombolytics, the stent retrievers. I don't know that they're getting dual antiplatelet therapy, right? It's just the minor stroke and TIA folks, right?
In one particular situation for a longer period would be the intracranial atherosclerosis patients, or if that's their primary mechanism for stroke, then there's many different studies, so we kind of still rely on some old studies that show some benefit of aspirin and Plavix over 3 months or a period of months, not really loading them, which is where the minor strokes get their benefit, but just aspirin 81, Plavix 75 over a period of 3 months to stabilize the vessel, followed by single antiplatelet therapy. And other particular, like special situations, if they were to get an intracranial stent or something, then they will need dual antithrombotics for a period of time. But the intracranial athero population might receive that. So there is also an ongoing trial called Captiva looking at different combinations of dual antithrombotic therapy for intracranial athero related strokes. And that's aspirin low-dose rivaroxaban combination, aspirin Plavix, and aspirin ticagrelor. All of them might have been individually studied compared to aspirin in large artery athro situations, maybe not all intracranial, but haven't been compared head to head to each other. So that will also be exciting to see in a couple of years, the results.
It's great. So I think that covers the sort of the acute management advances, say, over the last decade with stent retrievers and then all of the changes, even using TNK rather than TPA. We talked about that. And now the increasing role of dual antiplatelet therapy. But we're obviously going to need to do a part 2 where we talk about how to work up a stroke and what happens in preventing the next stroke. And we touched on that. We ended that with dual antiplatelet therapy in select populations, but I want to get into that a little bit more in detail in part 2. So can we have you back for a part 2?
Absolutely.
Yep.
Thank you both so much for joining me tonight. And I want to thank the audience again for joining the Penn Primary Care Podcast. Please join us again for part 2.